just go on? Do I start now? Okay. So, hi everyone. Thank you. For those who don't know me, my name is Jean-Marc Bourque. I'm a radiation oncologist at CHIM here in Montreal. So this will be session number 8, so reconciliation and Indigenous health. So we'll be hearing some perspective from Africa, New Zealand, and locally here in Canada. So to start, I'm going to introduce the first speaker, Dr. Christian Ntizimira is a founder executive director of the African Center for Research on End-of-Life Care. He's a Fulbright alumni and graduate from Harvard Medical School, Department of Global Health and Social Medicine, after completing medicine in Rwanda in 2008. He's also trained as African pain policy expert at the University of Wisconsin. He's a winner of the prestigious Talberg Stervos Nyarkos Foundation Eliason Global Leadership Prize in 2021 for his passionate advocacy for palliative care in Rwanda and elsewhere in Africa, based on his deeply held belief that dignified end-of-life care is a human right. He pioneered integration of palliative care and end-of-life care into health services rendered to a Rwandan cancer patient and in the community settings. In 2018, he became the first advocacy policy champion, making a significant contribution to developing palliative care in low and middle income countries for the World Hospice and Palliative Care Alliance. From 2010 to 2013, he was a director of the Kibagabaga Hospital in Kigali. He advised several governments on national palliative care policy, including Burundi, Rwanda, and Senegal, on access to palliative care services. He was a member of the Scientific Advisory Committee for the Lancet Commission on Global Access to Palliative Care and Pain Control. He was named the Young Leader by the Union for International Cancer Control in 2016 and Distinguished Young Leader by the Harvard Global Health Catalyst in 2017. His talk will be I Am Because of You, Connecting Communities, Reconciliating Identities in Global Oncology.
Good morning, good afternoon, everyone. Good evening. So it's a really pleasure to be invited by the scientific committee for this presentation, and I'm really happy to share the experiences from Rwanda and also hear from other experiences around the world. So I'm going to talk about I Am Because You Are, why it's really important, why we need this paradigm shift in oncology. We're connecting communities, reconciling identities in global oncology. So I live in Rwanda. Rwanda is among the smallest country in Africa, but not a small nation with 12 million people and almost 50% of the population under 20. And you can see the GDP in 2018 was $800. But also it's the most density country with almost 500 people by kilometer square. So most of resources is agriculture. So this is now 28 years after the genocide against the Tutsi, where 1 million people died during 100 days. But it's not only 1 million people died during the 100 days, but I think we lost also our sense of humanity during that time. And I strongly believe the concept of palliative care will contribute a lot to bring back the sense of humanity we lost during the genocide. Why? Because palliative care is not only about withdrawing or withholding medication, but it's about humanity, dignity, equity, social justice, and Ubuntu. And it was also really important to understand when I was studying doing palliative care, why it really history matters. And that is last 2 years when I finished my thesis in Boston, I just realized that some of my practice was really missing something really important. And I hope this article, my thesis will be published, I hope early next year, but I want to just share some of the findings. One, there is a historical shift in the meaning of death itself as influenced the patient end-of-life perception, because that time in Rwanda, traditional death was viewed as an achievement because it was considered as part of the normal life and the natural phenomenon, and it was viewed as a natural reprieve and the reward. And it was also the spirit of an ancestor and the high level presence in the family. So people was talking about death, and it was not scary that time because people was preparing to be an ancestor and a spirit of protection from the family. And also good death and bad death was totally viewed totally different, because good death was viewed when the social culture engagement from the family members and the community during the dying process. It was a privilege, not a hardship. And also having children that time was a criterion by the person was judging the society to have a good death, and it was represented that time the highest achievement, and which define a good death. And the perception of bad death was totally different. It's when person was dying alone without children, a wife, and other family members. And the post-mortem ritual was very important, because that's time when someone was dying before the rigor mortis process, the family members and the community has to put the dead body in the position of the fetus in the wound, and that was really important. And why death shift to become a source of fear? It's the adoption of a Christian belief during the colonial period, because that's changed completely the paradigm of death, and the perception of end of life, of course, changed completely. So because that time the Rwandans did have the concept of hell and heaven, because it would now become a choice. And during the colonial period, death as a penalty and sanction increased fear, and they changed the perception of death during the dying process. So the ritual of ancestors changed completely to the ritual of evil and evil spirits. So from why I became a palliative care physician. So my after seeing unnecessary suffering during the genocide against the Tutsi, my dream was to become a surgeon, because I thought that time that I would be contributing to rebuild the country. But until I met a very young guy who was really dying in pain. And I questioned myself, why did I spend so many years in medical school if it's just my role was to witness the suffering? And the sad story is his mom came to me and kneel before me and asked if I can do something for a child. And I felt that I failed twice. I failed as a physician because I feared to prescribe morphine that time, even if it was available in the country. But also I felt as a Rwandan, because in our culture, when a old person kneel before a young person, culturally you are failed. And I decided to change completely from a surgeon dream to a passion in palliative care. So why I am because you are. So this is the Ubuntu philosophy, and contrary to the Cartesian philosophy, I think therefore I am. Ubuntu talk about not I, but about we. It's also humanity toward others. And Ubuntu values life, dignity, compassion, humanness, harmony, and reconciliation. And this is something I'm continuing to learn within the context of palliative care, and now in oncology program here in Rwanda, because I just find that the Ubuntu philosophy, because it's a rooted African philosophy, is a response to self-suffering. And we all know that in low and middle-income countries, when you are diagnosed with a cancer, it's a death sentence, unfortunately. And people think, the side and the society completely, change the view and decide for someone who's really suffer from cancer, despite or contrary to someone who suffer from malaria. It's also a social justice, because that Ubuntu responds to the suffering, because we bring back the dignity of the patient, and also as a social justice, patient versus disease, because you can treat the disease without treating the patient. But if you treat the patient, you cannot mistreating the disease as well. And also in the system of social protection, when someone is diagnosed with cancer, there is expression here, people say is naked. So we use the community engagement as a what can I use the word we use as a blanket to cover the nudity of the patient. So using the community is also to cover the nudity of the patient. It's also a cost effective to improve healthcare outcome. Then this is what I'm learning now, how using Ubuntu philosophy to increase homegrown solution and also to contextualize in terms of care, but also reconciliation when decolonizing is really important. And the lesson I've learned from the last 10 years, one, to understand that it's also part of the mistake I did when I finished my school abroad, and I tried to duplicate a model I've learned from US in Rwanda. And I have to be honest, I failed many times, and I just learned that before to adapt something in one setting to another, you need first to adopt. You need to adopt the perception, then you adapt to the current challenges. And then I've learned that to be educated doesn't necessarily mean to duplicate the same model, but rather to adopt before adapting it. So, because if we try to adapt a program or a system from one setting to another, I think it's not education. There is an appropriate vocabulary for that. And also understand also the context in Rwanda. In Rwanda, social context, we have a saying, so when you are well, you belong to yourself, but when you are sick, you belong to your family. So there is no antagonist or polarization between patient autonomy and community responsibility. It's an intersection of both. Because the patient autonomy does not exclude the community engagement and vice versa. So it's and using this butterfly approach when you have both the patient autonomy and the community responsibility on the same time. And also I've learned also about the terminology. In Rwanda, we don't use end of life. We use life until the end because, as I said, Ubuntu values life and death is part of life. And it's why, because death cannot stop life. So people focus more about life until the end instead of say end of life or about death. And another word from French speakers, the word accompagner. I was very shocked when I traveled in France. People use, oh, I want to accompagner. Accompagner it was really strange because in our context, when you use accompagner, when someone is still alive, it's a very negative. And I just and I understood that, and just the translation was not done on a very on the context, because we don't use accompagner, but we use to be present, to be there, live with the person, to support and to assist. But accompagner is positive when the patient died. At that moment, accompagner has a very strong and positive perception instead of say accompagner when someone is still alive. And three things I need to just to close my presentation about what I've learned. It's also the context as a social justice. The model of palliative care we have of oncology in Africa is grown from the Euro-American clinical and culture experiences. And we need, again, to rethink about which kind of model we'll be using, which is value the critical element in our society. It's more about community-centered model, not necessarily patient-centered model as in different setting. And also meaning also it's a social justice, because part of my research I found that traditional palliative care and end-of-life care existed before modern palliative care exists. So they did call it palliative care, but the practice, the holistic approach was using that time was not so totally different, except access to morphine and the other treatment, which is now available now, but there is some similarity on term of practice. So, and if we need to, on my understanding, connecting global oncology communities, we need first to connect identity, and that is really, really important. And also culture, when we use international standard in oncology or palliative care, that cause sometimes can become a source of social injustice by not taking into account elements that are crucial for the dignity of the patient and the family members. So we need to be also careful when we say we need international standard or we need just to adapt from one setting to another. And there is a book we are now, I'm writing with some of my colleagues. It's the last 10 years observing more than 800 family members meeting. And I call it the Safari. Safari means a journey. And it's this book is to describe understanding the language of suffering from the families. And I came up with something really important, really easy to understand in our context, using 12 animal archetypes to describe 12 languages of suffering, 2 different behavior. I'm sorry, I think this is supposed to have the 12, but yeah, I'll be sharing. And I'm going just to share some experiences. One of the examples, what we call here giraffe suffering, it's a distance. It's the behavior, it's an unrealistic expectation from the family members. They ignore the reality of local resources. So our interpretation, giraffe suffering expresses mistrust about the skills and knowledge of the local team. So the management, it's difficult to go higher than a giraffe because in our language, to increase our language to communicate with the family members, it's just confidence with humility, which is the best answer. Another example is what we say hyena suffering. It's the conflict. It's when you have a family members with a lot of conflict, lack of dignity. People don't talk each other. Our interpretation, hyena suffering express a double antagonist feelings. The patient who is the source of conflict, but also the source of connection. So our management, we never argue with the family members. We don't judge, of course. Our first action is to protect the patient by working with the most influenced person in the group, and we call him the lion or the lioness, and then to take concrete actions. And the lack examples, it's about total suffering, defensive. So you have family members who really have a strong belief about cure. They deny completely about the disease. They come with a strong shield. And our interpretation of this suffering is torture suffering express a feeling of a second chance and they left behind because family members still believe that the patient's many things to do and there is an accomplished or unfinished work. So management, so language matters. So for the conclusion, we need, as I presented in the beginning of this year, so we need to go back on the soul of medicine, but that also required a culture change. The mandate of suffering to respond to the suffering is universal, but the most appropriate method to do are culturally relevant. And it's really important to adapt the framework, first to adopt, then to adapt the framework to place the humanity and the dignity of care. And also second, I think the previous speaker mentioned about it, train local leaders, sustainable training infrastructure, which is really important, invest in human resource because they are most resilient. The experiences of COVID-19 are showing that people, when fund withdraw, care continues. And also provide a innovative and effective cultural readaptation process. And the last, it's also the mutual beneficial relationship. When you have in high-income countries, a lot of fund for research, but in low-income countries, there is few researches, or some of the research questions from our partners are not really appropriate or adapted to our context. So also in the Global Palliative Care Partnership provide a unique and highly valuable opportunity for reverse innovation. And also, we need to understand the gap between economic realities and research expectation between countries. And my last and favorite statement, the way people die can reflect how the society live. Thank you.
Merci for cette belle présentation. Life until the end. I really like that. So for the next speaker, Dr. Michelle Mako. So she is originally trained as a cardiac nurse. She completed her Master's of Public Health at Ottawa University and has spent most of her career focused on public health and the Maori health inequities. Apart from a short term at the National Cancer Society, over the last 25 years, Michelle has worked in a range of government health sector organizations, including the Ministry of Health and the Health Promotion Agency, with primary focus on improving Maori health outcomes. She's currently the Equity Director for the Te Kahu, the Cancer Control Agency in New Zealand. Her talk will be weaving equity into national level cancer control.
Oh, sorry, Dr. Ms. Mako, I think you're muted right now. I don't think anyone can hear you.
Aroha mai. Aroha mai. Kia ora koutou. E te tuatahi taku mihi ki a koutou I ngā tangata tuatahi o ngā ao. Nei rata mihi ki a koutou. Ka mihi ana hoki ahau ki ngā tangata tūpuna, kua wihi atu I te pō ki o koutou a rangatira. Nei rata mihi ki a koutou. Ko Michelle Mako tēnei no te pōrewarewa o Aotearoa, e mihi ana I a koutou. Kia ora koutou. Can you see my slides? Yes? Okay, I'm going to go.
We can see.
I just want to send my warm greetings from New Zealand. In my introduction, I gave acknowledgement to your First Nations and Indigenous people. And I do mihi to the previous speaker. I have also acknowledged those of your tupuna or your ancestors who have passed, because for us as Māori, we always connect ourselves back to our ancestors and we greet them as part of the welcoming process. As noted in my introduction, I'm the Equity Director for Te Kahu e mihi ana ki a koutou. So first I want to just quickly talk about our name, ko Te Kahu. It literally means the binding thread of a cloak. So there in the picture you can see a korowai that has been woven specifically for our agency, or a kahu. And the idea of our agency is that we don't make up all the parts of the cloak, but we are the part that brings the threads together to create the garment that wraps around and supports whānau. And very similar to the blanket metaphor that was given by the previous presenter, it is an opportunity for us to wrap warmth around people going through cancer. And I also just want to acknowledge we do have a Māori leadership organisation that we work with, and they gifted us this name and they hold us accountable for holding the integrity of that name in all of the work that we do. We're also really privileged in New Zealand. We have a treaty, an Indigenous treaty between Māori and the Crown. And inside that treaty, or Te Tiriti o Waitangi, there are a number of, I guess, promises or expectations that we hold important in the work we do. And as Māori, we hold our government accountable for delivery. So the first concept is that of te rangatira, or the ability for Māori to self-determine, to take and hold leadership for those things that are important to them, and to be able to make decisions not only about their individual and community outcomes, but also about the outcomes that have been driven by government. It also promises a commitment to equity. In fact, I think the wording says something like Māori shall receive all the rights and privileges of other British citizens, which basically means that we should expect the equivalent outcomes that other people in our nation receive. There is also this idea of protecting our mātauranga Māori, which is our Māori knowledge systems, wairuatanga, which is our spirituality, and kaupapa Māori health methods, which is literally very similar to what we've heard already. It's about using the processes, beliefs, and structures that sit within Māori communities in terms of delivery and receipt of health. But it also promises us the ability to access options, so that as well as being able to access the same high quality services that all New Zealanders should have access to, that we should also be able to access options that are delivered by Māori, for Māori, and in uniquely Māori ways, and that the services we receive should be culturally relevant and safe. And the other area is around partnership. So it does promise that the Crown will partner with Māori in the governance design, delivering, and monitoring of public health services. So as an organisation, we have these four values: mana taurite, mana tangata, whai marama, and kia angitu. So we are driven by equity. We strive to achieve equity. We are very much about whānau. So whānau means family and communities. So it's about making sure that when we design and think about services, we actually make sure we put people and their whānau or families in the centre. We're also knowledge driven. So we're driven by the best available evidence and insights. And that includes not just data and research, but it also includes the knowledge and insights that is brought to us from Māori. And then we are outcomes focused. We're committed to delivering better outcomes. So I just want to paint a bit of a grim picture. As you can see from this slide, Māori have higher incidence of a number of cancers, particularly those which have poor survival. And we also have much higher mortality for a number of those. So in summary, in New Zealand, Māori are 20% more likely to get cancer and twice as likely to die from it. And so for us as an organisation, when we think about how we drive equity, because we have a treaty that says we have a requirement as a government agency to deliver equity for Māori, we also have a moral right because of the equity gap that exists. So I just want to use these words to frame my presentation. I'll read it out. Mā wai te kahu ahuru e kanoi moku mo te iwi mo te motu e. And it literally means who shall weave this cloak for me, for the people and for the nation. And this is the opening lines to a waiata or a song that's been written for our organisation. And we use it when we host official functions. All of our staff know it and sing it. And this waiata in Te Reo Māori is it's a metaphor for our role in being the aho that binds the threads to create the kahu. So I guess and under our first promise, it is about ensuring we have some equity and rangatiratanga in the decision-making process. So we do have an advisory council that gives advice to our chief executive and our senior leadership. This council were responsible for the establishment of the agency, and they continue to guide us on our work in terms of the direction that we take. And so you can see on my left, which might be your right, these are our Māori members of our advisory council. On the other side are our non-Māori members, but we are committed to a 50% of Māori on our council. Their role is to provide us guidance, leadership and direction, and it's really important for us that we have equity of participation for Māori at that level. We also have, as I mentioned earlier, a partnership arrangement with Hei Ahuru Mōwai, the Māori Cancer Leadership Network. So they've worked really closely with us right from the inception of the organisation and even before in the development of our Cancer Action Plan. And this ORT that I talk about here, it's basically a pledge. And it's part of the responsibility as a government agency being gifted a Māori name by Māori leaders. Behind that name, there is a pledge which describes the intention, the mauri or the life force, the mana or the importance of our name and our role in being what we need to be to uphold the dignity of that name. This organisation provides us strategic and cultural advice and support. They work with us to both to identify where are the most important cancer issues we need to address in terms of equitable outcomes for Māori, but also about how we do that and where we focus. They are a network of Māori cancer leaders. So in this network, there are Māori cancer researchers, there are Māori cancer surgeons, oncologists, radiologists, people working in palliative care and in the community. So it allows us, as we're working through our work, to access this expertise and to bring them into our house to help us with that work, and they facilitate that communication. So for us, this is not about consultation. This is not about us sitting in the office writing up what we think and then asking them, do they agree with us? We actually have members of Hei Ahuru Mōwai sit at the table. So when we're planning and designing projects, they sit with us in the decision-making process and in driving the direction, and they help us to develop the project and implement it. Similarly, again, as we've already heard, it's really important that we actually put the people at the centre of everything we do. So we have He Ara Tangata. He Ara Tangata literally means the pathway for people. And this is a group of people who have lived experience of cancer. And once again, we have a strong commitment for 50% of that group to be Māori, and that is both in terms of equity of voice, but also as a significant partner. And again, they provide us advice and guidance. And in projects that we deliver, we invite members of He Ara Tangata to sit in the project. So again, we pay them to sit as members of our projects. They come to our planning meetings, they give us advice and direction, and they keep us accountable for making sure the work that we do is appropriately targeted towards the unique needs that they have as consumers of cancer services. We also access Māori clinical research and expertise in our work. So this is just a number of some of the Māori clinical experts that, again, they don't sit on the outside, they actually come into our work, they provide us strategic and targeted clinical advice, but importantly, they bring a Māori health and cancer inequity expertise to our work. They peer review us, they act as a critical friend, and they contribute through working in our strategic group. So again, in this group, we have public health leaders, we have radio-oncologists, we have surgeons, we have public health people, pharmacists, and a medical oncologist, and also hematological experience. So they bring us a really in-depth knowledge as Māori cancer leaders working with patients in the hospital and health service. This is a piece of work I'm going to spend a little bit of time talking about, Ngā Kōrero Hāpore, which literally means community voices. So in 2020, we ran a series of Māori community hui, where we went out into the community and we invited Māori with experiences of cancer. We invited iwi or tribal leaders, Māori providers to come and talk to us about what were, in their view, the significant issues that we needed to think about in terms of cancer. So at these hui, we had around between 2,800 and 3,000, it's not an exact count, attendees came to these hui, and we ran a series of small workshops inside each hui or meeting to talk about things like palliative care, primary care, detection of cancer, mātauranga Māori or Māori knowledge systems, public health, Māori health leadership. So we canvassed a wide range of options for them to talk about. And we're in the final stages now of preparing and presenting the report back to them, which has been also through a series of leadership workshops where we pulled Māori leaders together to also bring their perspectives on what we heard. And for us, this piece of work is really important because it enables us to ground our work in the voices and the aspirations of the people from the communities. And here's some of the things they told us, what they told us about their experiences, that the system isn't designed for them, that it's designed and delivered in a way that is designed for clinicians and those things, and very similar to some previous comments, in our whānau or in our families, cancer means that we have to start prepping for a tangi or a funeral process. They also told us about what we do with data and information that we gather, the language we use. And I really like this quote. I thought metastasized was something that happens to cows. And again, we use language that is impenetrable for our families and for our communities. So they told us that the way we use data is dehumanizing and re-traumatizing and complicated, that we use their data and we forget that it belongs to them, that again, whānau or families should be the custodians of the data because they are the ones who are going to support the person to get well. So again, we're using these thoughts to try and understand how we build that into our work. So just very quickly, I want to talk about some internal capacity and capability things that we're doing in terms of our organisation. So first, we have a strong focus on developing our people. If we're going to be effective in working and delivering good advice and direction for Māori communities, our people have to understand what that means. So we are continuously bringing our staff into Māori environments, onto marae. Marae is the cultural home for Māori, bringing them to workshops, providing them tools and resources. We have a real focus on Te Reo Māori, so most of our staff are learning the basics of how to introduce themselves in the Māori language. And this is just a way of assisting our people who are working really closely with Māori leaders in the work that they do to have a really deep understanding of the skills and knowledge that they need to have to do that. But we also have a focus on building our organisational capability. So we've been developing tools and resources to build the capability of our staff to work. So, for example, we have training around what is Te Tiriti o Waitangi, what does it mean, how does it apply to our work? But also in this green box down here, we've actually broken down those 5 principles I mentioned earlier, and we've started to help our staff understand how we consider those things when we're planning a project. We have a capability development plan that we're implementing. You'll see over here in the top right-hand corner, e tipu, that's our Māori language commitment. So most of our publications have a degree of Te Reo Māori built into them, including translation of certain aspects. And we also have a group that I facilitate called Te Mana Kahu I Taurite. And this group is a group of people who are not Māori and not actually also in equity roles, but their job is to make sure that every project they deliver has considered equity. So in our project proposals, you cannot get a project signed off if you have not answered questions like, who is most affected by this issue? In what ways are they affected? How will this project address the inequities? How are you engaging people affected into your decision making? So we really critically examine the equity issue inside every project, and you do not get your project signed off and you cannot proceed until you can describe how you have considered these issues. So I am coming to a close, and I'm sorry if I've taken us over time. I did want to close with these words, and the waiata goes like this. Maua te kahu ahuru e kanoe, me hoki ki te whanau e. So these words mean we need to ask ourselves, for whom do we make this cloak? We make it for our whānau. Nō reira, tēnei te mihi kia koutou e te hunga whakarongo, tēnā koutou, tēnā hoki koutou katoa. Thank you for listening.
Thank you, Dr. Mako, for what I think is for you Saturday morning, which is very
It is Saturday morning. And actually, I just need to declare I'm not a doctor yet. I'm halfway through my PhD.
Okay. So for our last speaker, a fellow Acadian and my past chair, Dr. Marc Gaudet is originally from New Brunswick. So he completed medical school and residency training here in Quebec at Laval University. During his residency, he completed a master's in clinical epidemiology from Laval University and part of the Royal College Clinical Investigator Program. He then went on to do a clinical research fellowship in GYN at the BCCA in Vancouver, as well as a master's in health administrations from the UBC. After his fellowship, he served as staff radiation oncologist and headed Gatineau, Quebec, where he spearheaded outreach clinics in Abitibi-Témiscamingue region. He's currently staff radiation oncologist and head of the radiation oncology program at the Ottawa Hospital, as well as associate professor of radiation oncology at the University of Ottawa. His current research interests includes inequalities in access to cancer care, cost effectiveness of cancer care, and implementation of new radiation technologies in low and middle income countries and remote locations. In 2022, for which he will be talking about today, he became one of the first 2 oncologists ever licensed to practice in Nunavut and has since co-led the cancer care clinic in Gaudet. He leads ongoing efforts to increase access to cancer care for rural populations and northern populations.
Okay, here we go. So I'm a soft shocker, so if you can't hear me, just let me know. So I just first like to thank the organizers for inviting me to talk about our work up in Nunavut. So essentially, you could argue that I've had arguments from people in my own center saying this is not global health. And last time I checked, Canada was part of the globe. I mean, we do want to have efforts to help individuals who have inequities in access to cancer care and all that. So I'm very glad that we're invited to speak about Canadian experience, or Nunavut experience, I should say. So I see here. So one of the disclosures I have is I honestly don't consider myself an academic expert on global health. So I mean, I'm first and foremost a clinician. I knew I was a soft talker, good thing I mentioned it. So first and foremost, I'm a clinician. And I mean, one of the things we see in Ottawa is when we see our Inuit patients or folks from up north, I mean, we see the difficulties that they face, and I've developed quite an appreciation for our Inuit populations and our northern populations and where they are from. So you can see a few pictures here of different places up north. So we'll move forward here. Here we are. So, I mean, just as a background, so we don't always think about how vast Northern Canada is for the small amount of population there is, right? So there are about 65,000 Inuit people in Canada. About 2/3 of them live in Inuit Nunavut, or the homeland, which is comprised, as you see here, of essentially Ntizimira, which is Northern Labrador, Nunavut in Northern Quebec, the territory of Nunavut, and the Inuvialuit region, which is essentially the region of Inuvik and the Mackenzie Delta. So they are spread out over an area that is about 5 times the size of Texas, and that's about 40 or 50,000 people over that area of land. So it's a very, very large area. We split up Nunavut itself into 3 distinct regions. So we in Ottawa mostly will see people from the Kiktani region, which is the essentially Baffin region, or the eastern region of Nunavut. So I'll mostly be talking about that region because those are the folks that we see most. Just a few pictures again from up north. So just like I say, fantastic lands. Just difficult to comprehend, having been there, how people can survive there with some of the harshest conditions you can imagine, with winds and the cold. And I mean, these people have survived there for thousands and thousands of years, and I have trouble spending half an hour outside when it's that cold. So there we are. So we'll move forward again. So I mean, the Inuit populations in Canada have a very long history. So they date, I mean, their presence there dates back over 5,000 years. They are people who are extremely resilient and have very strong traditional values that, again, essentially, in a peculiar way, mirror what we were just talking about in New Zealand. So the importance of the land, the importance of their family and daily life and making decisions. So decisions are never made individually. So the family is very, very important, and that comes into play when people are being brought outside of their homeland for care, right? If they're brought without their family and need to make decisions, that's a very important point. They're also very hospitable, welcoming, even in the face of hardship. So culturally, you're not supposed to show the fact that you're ill, and maintain kind of a front and continue to help others even though you're ill, which is one of the things that we see. The unfortunate reality is that the Inuit in Canada have seen rapid acculturation in the last century, and that leads to many disparities that we see, and we can call that the fallout of colonialization. And if we look at pretty much any indicator, any health indicators, they're all quite different between Inuit populations and either non-Inuit in Nunavut or non-Inuit in the rest of Canada. And they're not a little bit different, they are drastically different when we look at these numbers. So understanding kind of where individuals are coming from, oftentimes I think the best ways to tell a story, and over the summer I spent a week in Northern Labrador, and Sophie that you see here is actually a Labrador Inuit elder who was actually there to teach us about their culture and about the land. And if we look at histories of where people have been, you kind of understand why they are a bit suspicious of us Southerners trying to help, right? So if we look at her history, Sophie was born in Rose Island, which is a small island in Saglek Bay in Northern Labrador. Rose Island is a place where about 100 and so remains of Inuit elders were removed in the 1970s to be studied. So their remains were moved to Toronto to be studied by a PhD student, obviously without permission from anybody, and they actually brought back in 2015, I believe it was. which is, again, horrendous. So she was born there on Rose Island. Her family moved to Hebron, which is a little hamlet a little bit further down south, again in northern Labrador, and they were forcefully removed from there in 1959 when they were, again, forcefully relocated. And they ended up relocating to a place called Mako, a little bit further south in northern Labrador, which is a drastically different geographic place. So they used to live above the tree line and were moved below the tree line in a very different geographical place. And eventually were very unhappy there and moved up to a place called Port Burrell, which is actually in Nunavut, which was also forcefully relocated in 1978. And then eventually she landed in Nunavut in a place called George River. And was eventually faced with a breast cancer diagnosis, for which she was treated here in Montreal. So you can imagine how that pathway taints your view of how you are to be received down south, right? And that's just one story. And Sophie's story is actually available. She's actually very involved with the Inuit Women of Canada, who are a group who have done a lot of work to help cancer patients, and they actually have a lot of online modules and things, so you can actually find her story online there. And this is just a picture of her fishing for char this summer, which is kind of cool. So one of the things about, again, suspicion of us Southerners, and I'll include myself as a Southerner, a lot of the Inuit research that has been done, and this is from essentially an Inuit research group which has been recently formed. They are amongst the most studied Inuit or Indigenous populations in the world. And honestly, the biggest beneficiaries of that research are the researchers themselves, right? And that is where suspicion comes in. And I have reached out to different individuals with the work that I'm now doing. And the first question I'm asked is, well, what's in it for you? What do you want? Like, clear as day, like that is what comes out first. And I think that is an angle that I've now learned to navigate that space, and it taints the way that we've now run the clinic in Iqaluit, because I had initially come at this from a clinical point of view, wanting to help our patients. And again, in reaching out, that's what we see is that suspicion, which I now completely understand. So the research that comes out is often like this. So Nunavut is worst at this, Nunavut is worst at that. It is very bad. That's what comes out. But the follow-up question to that is, well, what do we do about it, right? And that's the big thing that loop has never really closed. And that's the perception that folks from up there have, is that we're never closing the loop. We're showing that it's bad, and then we go away. So that's kind of, again, where we're coming at with our initiative. And there is some truth to those stories, though. So if we look at cancer statistics in Inuit, in population of Nunavut, they have amongst the highest lung cancer rates in the world. So I mean, that fact is undeniable. And those numbers are actually ever increasing. So if we look at trends, they're actually increasing still. How do they access cancer care? So, I mean, historically, there's a few different pathways that our northern populations actually use to access cancer care. They either go west or go kind of straight south. So those from the Kiktani region are essentially referred to Ottawa. There's a little bit of intervention in Iqaluit. So if you think about the more northern communities or more remote communities, they will sometimes go through, or often go through Iqaluit for an initial period of tests or initial evaluation. So there's a certain amount of things that can be done there. There is a CT scanner in Iqaluit. There's a mammogram machine. There's 2 ultrasound machines. So some of the things can be done there. There's rotating general surgeons through there so they can get biopsies and things like that done. But it's, I'd say, relatively basic. And then people get sent down to Ottawa afterwards. People in Western Nunavut will usually get sent down to either Winnipeg or Edmonton, but there's essentially no kind of clear cancer care or clearly defined cancer care in the territory as of yet. If we think about how that's done elsewhere, so, well, there are multiple other jurisdictions in the circumpolar region that have similar realities with fly-in, fly-out realities where there's no roads that lead anywhere, very difficult weather conditions, very cold conditions. So I mean, if you look at Alaska, you look at Greenland, you look at Siberia, they also have models of care that somewhat mirror what is done in northern Canada, with the difference that there's a lot more that happens in that intermediary step. If you look at Greenland, a lot of things happen in Nuuk. and then they get usually flown to Denmark for care. But there's a lot more triaging or a lot more work that gets done initially, which is the step that we're kind of missing out on. The other reality, and if we look at kind of where Ottawa fits into that, we see about 40 or 50 individuals from Nunavut every year with cancer. So it's a relatively small number of people. And then when you break that down into individual cancer sites, it makes for very small numbers, right? But the vast majority of people we see either have lung cancer, colorectal cancer, and there's a small subset of head and neck cancer patients with actually nasopharynx cancer that we see. But it works out to relatively small numbers, right? And these individuals travel very far. So they travel about 2,000 kilometers, which is a direct flight from Iqaluit to Ottawa. But face drastic social differences when they get there. So I mean, you're going from a city of 8,000 people, which is probably a radius of about 5 kilometers. You land in Ottawa, which is 1 million people. Drastic differences. If you're leaving from one of the smaller remote communities, you're leaving 300 or 400 people to get to a 1 million person town, and that creates a lot of difficulty in accessing care or desiring to access care, because a lot of people know that if they're going to come down to Ottawa, they will be there for 6 months, sometimes 8 months, without actually going back home. And they have seen many family members pass away in Ottawa. So it's not something that's desirable, and it can be very difficult. And if we look at more recent experience, so again, mirroring some of the talks that we've seen earlier today, we've looked at kind of how that's gone throughout the pandemic, and about the only metric we have for a number of cases up north is the number of people that we see in Ottawa, and that honestly didn't change very much throughout the pandemic. A lot to do with virtual consults though, so the number of people that we assessed were about the same, but if we then translate that into the number of people who actually came down for treatment during the pandemic, that dropped by about 50%. And I mean, we can very clearly attribute that to the difficulties with quarantine and being away from your family, and even more. So every time you'd want to go back, they would actually quarantine in Ottawa prior to returning home. So I mean, there's a very difficult time trying to get folks through treatment, and that was the same through either systemic therapy or radiation therapy. And I had a bit of a case study, but I'll go through most things just in the interest of time. But the real question is, does that tell the whole story, right? So we've looked at numbers, we've looked at logistics. What does that mean for the individuals that we're bringing down, right? So the actual reality of it is, and what my case study was going to illustrate, is that oftentimes people are in a bit of a holding pattern before they come to Ottawa. So the story that I was going to tell is one of our patients who was actually flown down from a smaller community up north, and actually spent 3.5 weeks in Iqaluit waiting to be flown down to Ottawa for an assessment, for a CT scan, an MRI, a PET scan, a biopsy. So usually that's all done very quickly once people get down. But she was essentially lodged in Iqaluit for about 3.5 weeks waiting to come down, and landed in Ottawa extremely unwell, went to emergency, and actually passed away about 2 days after landing in Ottawa, which is a very unfortunate reality that we see way too often. And the issues that the Inuit bring up is the lack of involvement in that decision process in designing how cancer care happens. And essentially, this is a study that was carried out about a year ago, and essentially what we see is things like this. So they didn't explain anything. I didn't know what was going to happen. They basically just told me I was going to Ottawa, and that's it. I didn't know what was going to happen. I thought I was going to be cured. When I got there, I was told that things were palliative and I maybe had a few months to live. And if I would have known that, I might not have gone to Ottawa. And that's kind of the key piece that's missing in the whole process, right? Is informing people before they come to Ottawa, and actually having them and their families participate in that decision process. And that's where kind of this notion of, so there's multiple different initiatives that have been done. So some of it from Inuit organizations, like I was saying, like Inuit Women of Canada, they have a fantastic series of learning modules and things that you can look at. Many of our clinicians, like Dr. Asmus that you see there, have done lots and lots of education up north and developed very significant partnerships with our colleagues up north. But again, if we come back to that suspicion of us Southerners who kind of fly in, fly out, but don't necessarily invest time. One of the things that kind of became the impetus between us actually going up on the ground in Iqaluit. So one of my colleagues and I, Dr. Perry, decided to pursue that initiative about a year ago. And our first clinics we'd actually planned out in April of last year. So it was it got delayed quite a bit because of the pandemic, but in April we were actually able to go up north and essentially we met with multiple different individuals up there, met with NTI as well, who's the Inuit organization up there as well, and essentially planned out how that would happen. We actually ran kind of a mock clinic with one of the GPOs up there, who was seeing patients with us, kind of looking over her shoulder there. And a lot of them were actually my patients, so it was kind of ironic to see them there. And then we essentially decided to implement that clinic. And I'll close out here in a few minutes. I apologize for being over time. So in implementing that clinic, I think it became very important to know how things work in Iqaluit. It's a very different reality from what we know in a big city. So we met with the chief of staff, with their nursing staff, with their management, with NTI as well. And again, we ran a mock clinic to kind of see how things would go. And then we ran our first clinics in July and October of this year, which went very, very well. Our first clinics were essentially looking at follow-up care. So we didn't want to aim too high. So, I mean, we essentially chose patients who were already known to us, who were in follow-up patterns. So we were seeing patients in follow-up. And the thing that we realized is that patients were a lot more forthcoming about what was going on if we were seeing them close to home, right? So I saw many of my own patients and spent a lot more time with them and learned a lot more about their symptoms because they weren't afraid of me keeping them in Ottawa for tests and things, right? And they actually outright said that to me, that a lot of things came out that probably wouldn't have come out otherwise. And I mean, there's lots of advantages to the clinic's travel cost. Again, we have access to the hospital. We can get CT scans the same day up north. But there's challenges, again, with communication with our specialists in Ottawa. One of the things that is seen is that we're kind of diluting expertise by only a few of us oncologists going up there. And again, making sure that we're actually going to own up to it and continue to go, right, is one of the big things that we have to see. So the next steps, I'm actually going up in about 2 weeks. So we're actually going to start seeing new patients is our next kind of step. Especially in the palliative setting, if we can kind of triage people a bit better, or hopefully much better, before they actually come down to Ottawa and inform them much better about what's coming. That is our kind of next step. And we're also looking at maybe in the spring, going out to a smaller community, even if it's to see 3 or 4 patients, just understanding that reality and being able to provide care there as well. And I mean, eventually the next step is formalizing a cancer plan and a formal cancer program, which is the big step. And I mean, I've seen lots of experts on that here today and yesterday, which I was very, very pleased to see. And I mean, I'll be happy to communicate with a lot of you to see where that can go as well. So I was going to talk a little about difficulty of radiotherapy and systemic therapy, but I think we'll skip that for a question of time. If any of you are very, very interested in Northern Care, there will be a cancer care conference in Nunavut in May, mostly to talk about care in Nunavut itself, but there'll be a lot of our partners from NWT, folks from Edmonton, folks from Winnipeg, just looking at how we provide care for populations in the Canadian North. So if any of you are very interested, well, that is available, and you can communicate with me. Initiative very much to do with our Dr. Asmus, who's one of my colleagues who's led this, and it was initially planned for 2020, but has moved ahead 2 years now. So I think that's about all I had to say. And again, I'm sorry for going over time, but there you go. So thank you.
I think you stay here. Yeah, come here. Thank you. It was a really good session. I think it really speaks to the nature of what is global health, on how we have lessons learned abroad locally, and we can kind of transcends border. I forgot to mention at the beginning of the session to sort of like write your questions online if you had any. So maybe we'll start with that. If there's any questions online, if someone has access to it. It's probably because I forgot to say it at the beginning of the session, right?
I think Ben's been posting.
Okay.
In the chat for that.
are we waiting for Ben? Ben, is there any questions?
I don't see any questions right now, but I'll jump in if there is anything.
Okay, sure, if you want to. Oh, there is one question in the room. Do we have a mic?
Hi, thanks everyone for your presentations. That was a really great session. There was definitely a common idea of Indigenous populations kind of always having had the answers all along, and then a colonizing population imposing a different model of care on them. And so I'm curious, as when we work with Indigenous populations, how do you strike a balance of being supportive and kind of, asking the populations what they need and what they want without imposing a burden on the population? Because I know that sometimes there's a situation where any marginalized population can feel as though they're being expected to do all the work and teaching everyone about what to do. And so how do you strike a balance between asking others what they're looking for, what they want, while still being productive in that relationship and offering value to that?
Great question. Who wants to take the first? Michelle, thank you.
Kia ora, I'm happy to have a quick crack at that. So a couple of things I'd say in that. One, I think less of it being a burden and more about being a right. It's very much that whole adage of nothing about us without us. We have a tendency to make well-informed, research-based decisions or recommendations around what should happen. And I think it is just about recognizing that there are models of bringing people into the process rather than consulting on your process, which is more authentic. And I've never heard from the people that I work with that they feel burdened, because we pay them for their time and we value their contribution and we give them the opportunity to be at the start of the process and not just feeding back at the end.
Dr. Ntizimira, did you want to add something?
Oh yeah, I think what Mako said, I think it's a similar. I think one of the discussion I had with my colleague sometimes is in research is when some research question are developed from let's say it's an example from Canada, and try to compare an example from Princess Margaret Cancer Center versus in Rwanda Cancer Center, and sometimes I ask my colleagues, so what is the rationale compare the two settings? And we are not on the same area, we don't have the same resources, we don't have the same education, the perception of care is totally different. So what will be the rationale by make these questions, and how that question will be added? Will be added value in our setting in response. So I think respect and the mutual partnerships, and as I said, if we need to connect communities, we need first to connect identities, and that is really important.
I was honestly going to say about the same thing. Like, I don't think it's a burden. I don't think I've ever felt that in discussions that we've had. I think, like Michelle said, I think it's a right, and I think we should involve those folks as much as we can. And again, I've never seen it as, I've never received that they perceive it as a burden at all. They're always extremely enthusiastic about any input that we're asking for, because we haven't done it. Or I say we, as in, that's the perception that I have, that we haven't done it enough before. So I don't think it's perceived as a burden at all.
Thank you. And I think in the interest of time, is there any other burning questions in the room before we close it out in the interest of time? If not, I'd like to thank all the speakers and participants for this session. Thanks.